Good morning. My name is Josh Rosenthal. I'm at the Fogarty International Center, the NIH, and I was asked to help assemble a panel to think about environmental degradation and global health. I was fortunate to pull together a terrific group of speakers at relatively short notice, and so I want to start by thanking them for coming, and especially on Mother's Day, and thanking all of you for coming. If you traveled here, maybe it wasn't as big a deal, but for all those who are mothers, who are married to mothers, or who have mothers, well, thank you for being here instead of at home with your families. The CUGH has historically been a very focused, for I think very good reasons, on relatively downscale medical service delivery. And there is an increasing attention, I think, to global public health, as evidenced by the last session. If you were able to sit and listen to the terrific debate, actually, where they're really, as Jonathan pointed out, they were really talking about population health and how do you best facilitate that. The other reason this is a good time to be thinking about global health from the standpoint of the environmental component and how we may address that through environmental health was, I think, nicely set up by the first keynote talk here by Jim Tilch, when he talked about the progress, the partial successes we've had under the Millennium Development Goals agenda over the past decade. And as we look forward to now a new set of goals, the SDGs, that will be more inclusive, probably, and look to be examining health and aiming to improve health through a broader lens that includes economic development, social inclusion, and environmental sustainability, all clearly oriented at one level at the population scale of health improvement. So that's a very nice lead-in for this discussion. The traditional economic development that, of course, most governments of the World Bank have invested in and have been focused and based on resource extraction and industrial processes and energy-intensive development from agriculture all the way through to the way we construct our cities and the way we develop energy to light homes and cook for ourselves. And that process that economic development has been very successful at lifting over 1 billion people out of extreme poverty and many nations now into middle income status. So it would be foolish and naive to think that route is not really important in a continuing way. But there have been attendant health effects for that, tremendous growth and prosperity around the world. And while those who have been lifted out of poverty and have now access to medical care and resources have much longer livelihoods and better chances of survival, of course, through many health threats, they also have a new set and a growing set of disease burdens that are related to environmental degradation. Those who have not the extreme poor, the more vulnerable in the population world, have, if you will, a double burden from the traditional diseases of the poor, especially infectious in origin, but as well as the underlying resource base and the quality that they must live, whether it be air pollution or mining or effluents or many, many other processes. And when we think about where we go in the future, we have now both the unfinished agenda of dealing with the sort of urgent needs of the poor that include the traditional AIDS, TB, and malaria, waterborne infectious diseases, the growing burden of non-communicable diseases, hypertension, COPD, and of course a range of other diseases, but as well as additional threats from the resource extraction and energy use platforms that we've developed, emerging zoonotic diseases from deforestation, habitat fragmentation, intensification of agriculture, to horrendous air pollution that and a new understanding of what air pollution really is responsible for in our health around the world, and as well as perhaps the greatest challenge being global climate change, and how that affects all of our disease threats and has significant implications for how we think about both population health as well as access to services and where those services are going to be most needed over the coming days, but over the coming decades, but increasingly now, as I think you'll hear. So where we need to go, the environmental health community, is to think not only about the health threats from the environment, but begin to use that understanding in a way that translates some predictive power and an understanding of the disease mechanisms to a world where we can develop policies and interventions that are targeted at the appropriate scale and the time frame, and of course navigate in a world where there are lots of competing interests. But the science underlying those relationships that moves us toward appropriate policies, interventions, whether they be health services or others from other sectors, as we heard this morning, can't be done without a greater and greater understanding of those relationships, of the changes in the environment, the implications for health, and then what exactly we can do with those, when and where. So all four of our panelists today are really leading thinkers in this domain in a diverse array of health areas, which I thought would be of most interest. Understanding where those threats are and are moving in the policy domain or in specific interventions or both to act ahead of time, to act now and to look ahead over the coming decades, which is a challenging time frame for the health community typically to think about, but I think you'll find that these folks are really up to the task. So I will start then on the order and ask if Peter Daszak, the president of the EcoHealth Alliance, can join us. Peter Daszak is an old friend of mine who I've collaborated with in ecology and infectious diseases for a number of years. As the president of the EcoHealth Alliance, it's a US-based organization that conducts research and outreach in global health, conservation, international development. And Peter has been instrumental in identifying and predicting the impact of emerging diseases around the globe. And his achievements include identifying the first case of a species extinction due to a disease, the discovery of the disease chytridiomycosis as the cause of global amphibian declines, identification of the bat origin of SARS, identifying the cause of Nipah and Hendra virus emergence, and coining the term pathogen pollution. Did you really coin that term? And producing, yeah, there we go, the first ever global emerging diseases hotspots map, which is now widely used by USAID and others around the world, and hotly debated as well, which is very useful and important debate. Peter's on the NRC committees. He's on the IOM committee of the Global Surveillance for Emerging Diseases. IOM's Forum Microbial Threats, NRC Committee on Future Veterinary Research, a Standard Advisory Board member of the Australian Biosecurity CRC. He's advised Director of Medical Preparedness Policy of the White House, National Security Staff on global health issues, and he won the 2000 CSIRO Award for the collaborative research in the discovery of amphibian contritomycosis and is currently Editor-in-Chief of the journal EcoHealth. So, welcome, Peter. Thanks.
Thanks very much, Josh. Feel free to use the term pathogen pollution. It's really good. So I'm going to really focus on one disease system that shows us something about our relation to the landscape and how that can affect and drive infectious disease issues. I'm going to talk about Nipah virus, both in Malaysia and Bangladesh, and then talk a little bit about what interventions have been adopted locally at the community level, and then what about the big interventions for the future? Because clearly if emerging diseases are on the rise, which they are, and they're driven by things like land use change, something needs to be done. How are we really going to get that done? So let's start with Nipah virus. Nipah virus is an infectious disease, a paramyxovirus that's carried by bats that first emerged or was first noticed in Malaysia in a really significant outbreak. So the figure to the left are the human cases of Nipah virus from 1998 to 1999. And what you see is a long period where there are a few cases that were misdiagnosed as Japanese encephalitis in a place called Perak, where the little explosion is on the map. And that trickled on for actually way beyond that. It was a 2-year process. And then eventually a really big outbreak in humans in a place called Nipah, Sungai Nipah, which the virus is named after, in a different part of peninsular Malaysia. This is a virus that didn't infect people directly from bats. It went through pigs, which amplified the infection, and then humans were effectively dead-end hosts. There was no real or no known human-to-human transmission at the time. What we did, and under Fogarty International Centre funding, to try and understand why the virus emerged, and why did it emerge there in Malaysia, and why did it emerge then in the late 1990s. So we sort of went on this detective story back to the index farm. This is the place where the first human case was and the first pig case. And we had to do a lot of really old-fashioned epidemiology, wandering around, talking to people who were there at the time, who kept pigs, people who were there 10 years earlier, who were there when the farm was started. And what happened in Malaysia is there was a push to produce pigs at a very intensive level. So this was a big farm, and it was put on the edge of the town because it's a predominantly Muslim country, and this is a Chinese Christian related industry, really to supply Singapore. It was considered dirty. You put them out of the way, the smelly, dirty places, put them out of the way, close to the beautiful limestone hills in the forest there, which was a little bit unfortunate because that's where the bats came in. And if you visited the index farm, this is photos from Paul Chuara at the time, just after the outbreak, the pigs are all gone, they've been killed off, the farm's closed, but what you see are fruit trees that are over the pigsties, and the fruit drops into the pigsties. And these were planted really as shade for the pigs, because it's a pretty open structure, but very intensive. Brilliant records we could use for good epidemiology, and other than that, a really well-managed system. And you can see the rise in this industry, and what's really interesting, this pig and fruit thing goes together. All across Asia, you see the same thing. If you've got a single family farm or a family with 4 pigs, there's always a mango tree and a little pond with carp in. And it's sort of magnify that up 10,000 times. So you've got 30,000 pigs, a carp pond the size of 3 or 4 football pitches, and an intensive mango production facility. So these are the exports of pigs and mangoes from Malaysia, or the production over that period of time from the 1960s. And it rises almost concurrently, and then you'll see it in 1996, 97, there's a big cull-off of the pig population, farms are closed, and the mango production drops almost identically. Just fascinating stuff. So it's a dual system. It's a perfect system for fruit bats that eat fruit, mangoes, that carry a lethal virus that infects pigs to spread that infection. So we did a lot of work looking at bat migration patterns, and it turns out that bats do migrate very avidly across this whole region, and they follow the fruiting of durian, mango, rambutan, and other crops This is just a handful of bats we put satellite collars on. They cross political boundaries. They don't need a passport or a visa. And they lived right next to the index farm. There was a colony we found right there. So they were just exploiting that new resource really effectively, and by that way spreading the virus. But why did it happen then? Why didn't it happen earlier? If there were people there keeping small pig farms, why didn't this virus happen earlier? Well, this is all about our relationship to the environment. As we grow on our economic resources and intensify production, we tend to produce much more efficiently and just create these perfect conditions for this virus. It took a lot of effort to find out what happened, but we basically used a series of mathematical models to try and get every bit of information that we had, incredible data from every single pig on that farm, what happened to it, when it was moved from one sty to another, really detailed stuff. And Juliet Pulliam did all this work, really a fantastic bit of work. And run these models and try and re-simulate the exact conditions of the outbreak. And something very specific and weird, that the human cases trickled on over a 2-year period and started with a few very local infections, but then later there was this big outbreak. The pig infections drove that, so we're really modeling the pig dynamics and the bat dynamics and the viral introduction to try and reproduce these human cases. And this is what we found. What we found was the only way to reproduce the outbreak on a computer simulation with the exact parameters of that farm was to repeatedly introduce the virus. So we imagine the farm is set up, mango trees are planted, the pigs are produced, eventually the mango trees mature, we know exactly when that happened. The fruit bats come in, and after a couple of years are repeatedly feeding on the farm, and that we know the dynamics of virus in bats. It's fairly rare, but it's persistent. And eventually the virus gets into the population. You see this big surge in infected cases at the beginning there of the time scale, but the virus always dies out. There's not enough of a pig population to sustain the virus with a very high R0. What happens then is the virus is reintroduced after a certain gap. All the baby pigs produced in the initial outbreak have got maternal antibodies. As those maternal antibodies wane, they become susceptible and drive a second spike in infections. And as they repeatedly and consistently become susceptible over time, it keeps the fire of that epidemic burning. So this is why we had an outbreak that became a global issue. It's really agricultural intensification. It's the way we developed the land in Malaysia, which was unusual and new and led to this outbreak. And as you see it really nicely reproduces what happened with the human cases. Nipah virus, at the time, we'd heard these rumors of outbreaks in India and Bangladesh of an encephalitis. It was called aberrant measles. It was sort of talked in different ways. And it turns out with really good work, again, through funding from Fogarty, working with Steve Luby, Emily Gurley at the ICDDRB and Jahangir Hussain, eventually you start to see this pattern of a different type of Nipah relationship through the landscape. Where in Malaysia we had a very big outbreak of about 148 cases, I think, 248 cases, about 40% of those were lethal. In Bangladesh, we get repeated smaller outbreaks annually. So in Malaysia, one big outbreak related to this intensification. In Bangladesh, repeated outbreaks, now almost every year, smaller numbers of people affected, but really high case fatality. And some of those small outbreaks are almost 100% case fatality. So this is a lethal virus, and it's an endemic, consistent problem in Bangladesh. So why is that? Why are the dynamics different? And what we've found, and what Steve's group has shown, is that it's really all about date palm sap collection. So at a certain time of year, and this coincides with the Nipah virus outbreaks, people shimmy up the trees, they shave away some bark, the date palm trees, and put a tap in, and the sap, as it's rising, drips into a pot, which they keep there overnight and then sell in the morning when it's fresh. If you leave it too long, it ferments, and it's not appropriate to drink it when it's got alcohol in it, and it doesn't taste as good, I've heard. I don't recommend drinking it, by the way. The reason I don't recommend drinking it is if I can get this to work. Let's see. This may work, it may not. Okay. Never work with children or animals. There we go. And so this is an infrared camera set up at one of these date palm sap collection pots overnight, and you can see a bat attracted by the sticky sap dripping out, and it goes across and it licks and drinks and has a great time. And I think you missed it, but one thing that bats usually do just after they've eaten is turn around and urinate. Nipah virus secreted in the urine, and they urinate right into the pot over and over again. We've seen this many, many hundreds of times now. We know how long they come to the trees. We know which species come. We can identify them from the infrared photos, and we can even find Nipah virus evidence, PCR, from those sites. So it's a really good way for a virus to get transmitted. And it's a simple thing to stop. And Steve's group have been focused on this, working with FHI 360 to try and come up with a solution. I'm just going to see if we can see it doing its little... Going to the potty. Come on. There you go. There you go. Beautiful. It's worth the wait. Okay, I'll be quick. So what we basically found is that, this is a simple intervention, and Steve's group's developed some little covers you can put over that people could use to stop bats getting in. The problem is there's very little uptake, that people don't really understand the risk, but they're working on this. So at a population level, it's easy, relatively easy to control. But what about at the bigger level? If we've got land use change, deforestation, and intensifying agriculture globally, driving series of emerging diseases, what can we do about it? So working with USAID Predict, under a program we're calling Deep Forest, we've got 3 sites around the world where we're doing systematic surveys to look at the risk of pathogen spillover from wildlife to people across a landscape. And really nice sites in the Amazon, in Burundi impenetrable forest, and in Borneo. Different land use types, pristine through fragmented to urban centres, and doing repeated wildlife sampling of major reservoirs, rodents, primates, and bats. Human contact surveys to try and understand what people's relationship is to wildlife, how much contact they have, whether they hunt them, etc., across that land use gradient. How does making a land use gradient in a pristine forest over time affect disease risk because of these mechanisms? The science will be very interesting. We've just started this a year ago. It's going to be fascinating. We're going to get loads of data. I'm sure there'll be some good patterns. But what about solutions? This is an issue right now that we know about. This is a picture of Borneo. The big driver in Borneo is palm oil production. And what you can see are the rows of palm oil planted instead of native forest. It's a conservation issue. The wildlife in Borneo is pressed to the edge of these plantations. Plantation owners kill wildlife, pygmy elephants, orangutans, because they're kind of in the way. So we've been working with a USAID grant to try and understand leverage points in the industry where we can try and do something about it on a bigger scale. This is a map of emerging disease hotspots against concessions for mining and some timber concessions globally. And there's a really nice lineup. We know that there's huge expansion of mining and timber concessions in Africa and across Asia. It's a huge threat to conservation and health. And you can see the fragmented landscape we're working in Borneo. What we're going to try and do is value the ecosystem services of that forest, not just from a carbon perspective, but including the health value. If you leave the forest intact, you won't get viruses emerging from wildlife into people. That's the strategy. So how much does that cost? How much is the value of converting the forest versus the dollar impact of health when those diseases emerge? And ultimately to try and add that to the carbon trading platform that's been used globally to protect forests for conservation. I'll just show you very briefly, we've done a big global model for the Brazilian Amazon, and this is an economic model, so it's pretty nasty in the way they work. If you convert the land optimally, you follow the red pattern from 1970 to 2010, just economic optimization of the model. If you include, and that's for carbon and the value of the forest, if you include disease and the impact of just malaria from deforestation, which Jonathan Patz is going to talk about, the blue line is what you should have done. So you can see we're already losing money by converting forest in the Amazon, not just from a carbon point of view, but from a health point of view. And this is the same approach we're going to use in Malaysia. So I'll finish there and thank the funders as always, and I'll finally thank the bats too. Cheers.
Thank you very much, Peter. We'll hold questions and have 15 minutes at the end for discussion. So the next speaker is Jonathan Patz. Jonathan Patz is a physician and public health professor and director of the Global Health Institute at the University of Wisconsin in Madison. He co-chaired the health expert panel of the U.S. National Climate Assessment on climate change, which was just published last week, wasn't it? The third National Climate Assessment last week, convening lead author for the United Nations World Bank Millennium Ecosystem Assessment. And for the past 15 years, Dr. Patz has been a lead author for the United Nations Intergovernmental Panel on Climate Change, or the IPCC. Dr. Patz has written a lot of papers. I'm not going to go through all the numbers, but a textbook on health effects related to global climate change, co-edited a 5-volume encyclopedia of environmental health, and he's been very active in the policy world, where he's briefed both houses of Congress and has been on a variety of advisory boards, the CDC and the EPA, founding president of the International Association for Ecology and Health, and in addition to sharing the 2007 Nobel Peace Prize for the IPCC work, Dr. Patz received Aldo Leopold Leadership Fellows Award in 2005 and the Zayed International Prize for Environment in 2006, and carried the distinction of becoming UW-Madison Romney's faculty fellow in 2009. The one thing I will also say is that Jonathan was really one of the earliest people to begin to point out and identify the health threats to climate change when people were really just focused primarily on climate. So John has been an early and persistent and thoughtful voice on this.
Thank you, Josh. Thanks very much. Appreciate that introduction. So even though I've worked a lot on climate change, I'm not going to talk much about that because I'm going to talk about deforestation and malaria in the Amazon. Although, when you do hear about global environmental change, mostly what you think about is climate change. And I have to put this up here because just a few months ago, the IPCC came out with its 5th assessment report, and you can see the range of high and low projections for climate change. And I also have to put this one up because the 3rd U.S. National Assessment just came out on Tuesday, and you can see, the warming trend, and on the bottom in red are sunspot cycles. And there's a lot of climate deniers out there, and they're saying, yeah, it's sunspot cycles, it's something else, it couldn't be humans. But, this is just one reason why 97% of climate scientists out of more than 4,000 surveyed say the world is heating up and it's human-induced from fossil fuels and also by deforestation. That's about 20-25% of the problem. Now here's where I'm going to do a head fake because I'm not going to talk about climate change. Chris Ebuy is going to go into climate change later and talk more about the issues there. So the head fake here is deforestation. And thinking about global environmental change, there are lots of these worldwide challenges, from climate change to ocean acidification and nitrogen cycles, but I'm going to be focused in on the deforestation biodiversity story, biodiversity in mosquitoes actually. How quickly are rainforests being cleared? Very rapidly. Peter Daszak just came down from New York City, and we lose 1 hectare of cleared land per second, which is 2 football fields. In one day, we lose the area of New York City, and in 1 year, 9 million hectares are cleared every year. That's the size of the state of New York. So that's how rapidly forests have been declining around the world. And the issue is we have reasons that we're deforesting. It's for human, for consumption of wood products, for growing crops. Much of this is from agricultural growth. So there are trade-offs. There are trade-offs between land use for some reasons, and yet when we completely destroy an ecosystem, as Peter mentioned, these ecosystem services, these free services that ecosystems provide, many of these services we haven't really defined well enough, and that's part of the research that we're all doing to say, wait a minute, if you keep an intact ecosystem there rather than chopping the trees, you're actually preventing disease. And in this case, I'm going to talk about our research specifically on how intact forests protect us from disease. This all was brought together in a large way, an international assessment in 2005, similar to the UN Intergovernmental Panel on Climate Change. There was the Millennium Ecosystem Assessment Report that came out that asked the question, how do ecosystems serve directly and indirectly, but really, how do they serve humankind? And this is one of the chapters on infectious diseases, and you can see that various land use changes, we build dams for water and for power, for growing crops with irrigation. We have mining. We do all these activities for a certain reason, for economic development and societal well-being. On the other hand, what we haven't done enough of is ask the question, what are the side effects? What if we go in there and we chop down trees for one reason, and we're learning that there are some unintended consequences, and in this case, we're talking about infectious disease emergence. Now, looking back at the Amazon, this is looking at annual deforestation in Brazil. You can see that the line is showing cumulative deforestation. Now, Brazil implemented some very strict deforestation policies a few years ago, and deforestation levels dropped. There's also the question, if you go far enough in time and there's no forest left, that's going to drop anyway. But cumulatively, we are still, you can see the upward trend of deforestation. Recently, from illegal logging, this number actually has come up. But this is looking at trends in Brazil. And we asked the question, if you look at the types of disturbance in the Amazon, we looked at, intact forests versus deforested areas, you can see here. But we also looked at roads going into the Amazon, and we wanted to look at, the effect of building a roadway in addition to the land area change when you chop down the trees. This was led by my graduate student, Micah Hahn, who actually also worked with Peter on the Nipah virus. So deforestation, paved roads, unpaved roads, and also forest fires. And the orange fires are showing areas that burned in 1996 to 99, and also the red indicates more recent fires. So we looked at these different environmental changes across the Amazon, and we compared those environmental changes with malaria cases. Now here you can see that there are almost 500,000 cases of malaria in the Amazon. Almost all of them are in the Amazon region. And so this is malaria in Brazil. Most of it's in the Amazon. And you can see that this indicates timber production states across the legal Amazon, which is pretty much covers most of the Amazon. And when you look at those variables, what you see at the broad county scale and across that region, deforestation doesn't, at that level of resolution, you don't see a significant effect. What you do see in blue are the areas where roadway, if you have a roadway, you have an increased risk of malaria. Just to show you that, for example, in this case, you've got, for every 19 meters of unpaved road, a dirt road, 19 meters gives you a 55% increase in malaria. And you can see also significance where you've got forest fires and you have significant increases in malaria risk from fires. Now, what about in the timber areas? Well, this was looking at using Landsat satellites, which you can't see under the canopy. But working with Greg Asner at Stanford University, he has developed algorithms to take the satellite data and then run climate perturbations and show their signals that you can run and develop an analog to say, well, we can't see deforestation by satellite, but from additional analysis, you can actually pick out selective logging. And so this is sort of the innovation of this study, was to take a look at selective logging rather than just the coarse satellite imagery. So by using that method, looking at these timber production states, then deforestation shows up as more significant, but still it's here you can see at the bottom, moderate logging, up to 7% of logging gives you a 69% increase in the risk of malaria. Now, if you have severe logging and you cut down all the trees and you clear cut and you have a parking lot, well, you don't have malaria until it starts growing back and you have a matrix of secondary growth, and then it actually can rebound very badly. But in the short term, cut down all the trees and, you reduce malaria for 5 years. But here's the clincher here is that by looking at selective logging, you can see a 69% increase in malaria from selective logging. This is in Brazil. Now, if you come down to very fine scale where you have much higher resolution health data, this is work by another one of my students, Sarah Olson, and she looked at deforestation in one particular municipio, one little county in Brazil, and after controlling for human population density, finds that when you compare historic deforestation from 1997 to 2000, you can see deforestation here versus malaria incidence, and this is a Mac PC thing, but this is for every 4.3% deforestation, you saw an increase of 48% malaria incidence in a place where you have really good health data and you can see a strong signal. So scale matters when you do these analyses. And I want to end with a study that we did in the Peruvian Amazon. And notice that I have in yellow, this is another one of our superhero graduate students who's now an assistant professor at the University of Florida, Amy Vitor, who really led these studies. But the chair of our conference, Jim Tealsh, and I had a good time working on this while Amy was really slaving away in the field. That's another story about Michelle. We'll get to that later. We're still looking for volunteers. So the study site that we picked was along the Amazon. This is Iquitos, Peru, and they were building a new road to Nalta. And along that roadway were various extents of deforestation. You can even see sort of these parallel lines of deforestation here. Somewhere on there is an illegal airport too, but anyway. So we asked the question, all these dots indicate places where we collected mosquitoes. We did human landing catches, so we would catch the mosquitoes at night and speciate them, and then in the daytime, Amy and her team would go out and dip for mosquito larvae. And so when you ask the question, how does the mosquito number change? Keep in mind, a mosquito is not a mosquito is not a mosquito. What did I say? No, it depends what species mosquito you have. So there are plenty of mosquitoes in the jungle, but they aren't Anopheles darlingi species. That's the one that carries falciparum and vivax malaria in this region. So we're really zooming in on that species. So Anopheles darlingi, as you see, this is a pristine area, pristine forest. After controlling for human population density, we see very few of these mosquitoes in the dense forest. And then you can see the adult mosquitoes that we captured for this dangerous species go up with deforestation, controlling for human population. We collected these mosquitoes in abandoned agricultural fields, no people around. Those dangerous mosquitoes were there. So it was a deforestation link, not a human population link. And of course, mosquitoes don't just come from midair, they actually, they're breeding sites, and most of their time is spent in water. So we sampled for mosquito larvae, lots of sampling. I think this is one of the most intense field data studies on this subject of deforestation and malaria yet to be conducted. So over 5,000 observations dipping for larvae, and you can see that, if this is one of our village sites, a deforested site, a forest site, a secondary growth forest, actually, whatever. We ran transects, 1 kilometer transects. That's the road here. And the pixels are basically the 30-meter resolution of the Landsat satellite image. So this is just sampling. Every body of water along that transect was dipped for mosquito larvae. Anytime you came across a body of water and you just did that sampling, and we ended up with various different types of habitat. So you have a pristine forest here, you have a disturbed forest. Notice the open sunlit pool of water. You've got this swamp, and this is a fish pond. So we found that across those varying types of breeding sites and habitat, that parallel to the adult biting presence, which is the brown bar, the green bar indicates larval presence as well. So we found, Anopheles darlingi larvae in these disturbed areas after controlling for human population. So the story here is that we think that you disturb the landscape, you change the ecology, and you change the mosquito biodiversity, and you have an entomologic risk for malaria. So I'll end by saying that these sentiments have been talked about by world leaders, and the lecture this morning by Peter Piot was incredible when he said, sustainable health, for sustainable health, we need a sustainable planet, and that health is far more than just the health sector. Here's Director General of the WHO showing a report that came out looking at the link between our planet, our health, our future, talking about these interlinkages between ecology and health. So thank you very much.
Thank you, Jonathan. Our next speaker is Sumi Mehta is the Director of Programs for the Global Alliance for Clean Cookstoves. And Sumi and I have been working very closely together recently on cookstove and household air pollution research. She was a member of the WHO expert group for the development of the WHO Global Air Quality Guidelines, as well as the Indoor Air Quality Guidelines for household fuel consumption. She was involved in the first effort to estimate the global burden of disease from household air pollution. I think she's going to be telling us some about that. And was actively involved in the recent update of the burden of disease estimates for HAP and outdoor air pollution. She's worked on exposure assessment in household air pollution and a lot of focus on the cost effectiveness of interventions. And she's also been the scientific lead for the Health Effects Institute's Public Health and Air Pollution in Asia program, and is a health policy analyst at the WHO. Field experience in India and Vietnam, and she has worked extensively with colleagues in China, Thailand, Mexico, Brazil, and Chile. Thank you, Sumi, for joining us.
Okay. So good morning. I think it's still good morning, right? Barely. So I'm going to be talking about, of course, an issue which I think it's been really recognized more as a household energy or an environmental issue more than a health issue until relatively recently. And this is an issue where really every day we still have around 3 billion people, or 500 million households, who rely on traditional fuels and stoves to cook their meals on a daily basis. And I just want to emphasize that until pretty recently, in the absence of kind of concerted efforts to address this, the number actually hasn't really changed. So you do hear about the percentage of people going down, but I just want to emphasize, so in 2000, 3 billion people were how many people that were actually cooking with solid fuels, and that was about 50% of the world's population. In 2010, that was around 40% of the world's population. So even though the relative number may be decreasing, in terms of absolute numbers, it really remains a major issue. And so I'm going to talk a little bit today about what the state of the burden is, and then give you an idea about where we are in terms of trying to move towards looking at solutions related to this. We know now, depending on which risk assessment you look at, that household air pollution causes around 4 million deaths each year. And we have really good evidence now from the epidemiology to focus on chronic lung disease, COPD, child pneumonias, lung cancer from both biomass as well as from coal now, and as well as for cataracts. We also have a lot more evidence that's coming where we're looking at kind of the consistency across the range of combustion risk factors. So looking at what we know from ambient or outdoor air pollution, passive smoking, and active smoking as well, that gives us an idea about how we could actually link between household air pollution and cardiovascular disease. And I think also a lot of emerging evidence on adverse pregnancy outcomes and some developmental effects as well. But I'm going to just leave those off for now because we're really talking about the evidence from really large global comparative risk assessments where you have to make sure that the state of the evidence is kind of up to par compared to other risk factors that were also explored. And when you look at it, actually, you'll find that this really did end up as one of the top global health risk factors, really right up there with a lot of the kind of, I would say, you've got kind of the mix of the underdevelopment and the overdevelopment, and looking at some of the risk factors like high blood pressure, tobacco, some of the dietary risk factors. But I also want to caution, and you can look in more detail if you want to, that this is something where in some cases it's a little bit tricky because malaria, for example, was looked at as an outcome rather than a risk factor. So if you would put that in, then things would change a bit. So I wouldn't say the top 5. I would say that it's really among the top here. And the major causes of death, what you look here, as I mentioned, is really pneumonia, COPD, lung cancer, and cardiovascular disease. And really about 6% of global deaths being attributable to household air pollution. And the colors here, if you look at, these are really what the different health outcomes are that you focus in on. So if you look at the full report in Lancet, you can actually see what the actual cause of death is by the different categories. Yeah, and I apologize that it's difficult to see that fully. And I also wanted to kind of caution, in terms of, really thinking about household air pollution is not an issue that just stayed inside the household. This is really a leading source we know now of outdoor ambient air pollution. On a global scale, probably contributing about 15% of the actual ambient levels. But in some regions where there's really a high proportion of people using solid fuels, really a substantial burden, up to about 1/3 of air pollution in India, for example, is attributable to household burning. And this is really something that you have to consider because it has very different policy implications if people know that they're not actually going to be able to achieve their ambient air quality standards without actually looking at this household issue. And I also wanted to emphasize that we found that this is really a leading risk factor for non-communicable diseases in developing countries, and it's something that is, I think, often overlooked because people think, if you think about rural women, for example, they're physically active, they don't smoke, they don't drink, they're not overweight, and yet you have this as a really leading risk factor among most of the bottom billion that people have to contend with. And this is something which I think there's a lot of increasing awareness with now. Actually, the Southeast Asia region of WHO, which includes India as well as Southeast Asia, they last year actually passed a resolution saying that, we really have to make sure that for our region, household air pollution is acknowledged as a major risk factor. Because otherwise we're not able to really address the real risk factors that are present within most of our population. And for those of you who want more technical information, you want to see the colors on the bars or really get a better sense of it, I've just included a slide here that people should be able to access later, so you can get much more information on how all of this was kind of estimated. Now, it's one thing to say, okay, so we know that there's a problem. So household energy, household air pollution really is related to health impacts. But the question is, well then, can we actually take this and then say that we can actually demonstrate that adopting cleaner cooking solutions is actually going to save lives? So we know that there's a problem, but do we know how we can actually address the solutions here? And I think that from a public health perspective, this is what we really want to know, right? Because we say that this is a public health issue, but it's something which is actually, I think like many of the talks that have already gone already this morning, it's something which is actually outside of the clinical setting in terms of thinking what the solutions are. So you have to be very careful about how you're going to recommend that these things get addressed. So we've talked about household air pollution, but of course it relates to ambient air pollution. We have to think about what kind of fuels are actually available. Are they accessible? Are they affordable? Are people going to be willing to use them? Are they going to keep using their old technologies? And also, in many of these settings, you also have to think about the competing risk factors as well to make sure that somebody is not going to suddenly have clean air, but then you're not able to address other risk factors, and so they'll end up, succumbing to something else. So I'm actually with the Global Alliance for Clean Cookstoves, and I just wanted to emphasize we're talking more about the health today, but what we really focus on here is not just the health impacts, but really trying to think about how we can have the creation of a thriving global market for clean cookstoves as well as fuels so that we can actually address the range of impacts that are currently being experienced and really help to save lives, improve livelihoods, empower women, and also protect the environment as we're doing this. And our goal is, of course, 100 million households adopting clean and efficient cookstoves and fuels by 2020. But I just want to emphasize that we're really thinking about this adoption issue as being critical because you could have a lot of people starting to purchase better technologies, but it doesn't necessarily mean that you're going to see the benefits associated with that, and that's what we're most interested in, of course. We have now over 1,000 partners, including many active implementing partner countries that I'll just go into in a second here. And I just wanted to emphasize that, of course, although we're a global alliance, it's not possible to be everywhere at the same time. So we really try to utilize a focused geographic strategy. You can see on the map here, the countries in green are really our focus countries. So it's Nigeria, Ghana, Uganda, Kenya, India, Bangladesh, that you can see here, and Guatemala. And these are really areas where we're focusing not just on health research, not just on the markets and development, but a range of different activities so we can really have a convergence of efforts to really move things forward. And of course, because we are interested in health, I just have to emphasize that we're really focusing in the countries that make up about almost 3/4 of the burden of disease due to household air pollution. And this is related, and I'll get into it, but there are other issues related to standards, advocacy, and other tailored market development efforts that all come hand in hand here. So I guess the first question that everybody probably wants to know is, well, if you want clean cooking technologies, how do we actually define what's clean and what's efficient? So we actually have developed a global standards partnership, both with ISO, the International Standards Organization, as well as with the World Health Organization, so we can make sure that we can actually clearly define for people what is actually a clean cooking technology. Whether it's a stove or a fuel, we can really know that. And so we're working hand in hand with these, and very happy to say that the WHO air quality guidelines, which are focused on indoor air quality, were just recently approved and are going to be released in the near future. And the first ISO meeting focused on this issue was actually held in Kenya in February of this year. And based on some of the interim work that's been going on with this, we actually do know that there are now some more clean stove and fuel interventions that are available when you're actually defining clean in terms of either the fine particulate emissions, which is the most common indicator that we look at for health effects of air pollution, as well as for carbon monoxide emissions as well. And again, this includes not just the biomass technologies, but also the cleaner fuels as well as electricity. And then the issue is, okay, so we can say what we think is clean is, but are we really getting clean enough to impact child survival? And this is an area that we've been actively engaged in terms of really trying to support and leverage ongoing research and also commissioning new research that really looks at the link between clean cooking and adverse pregnancy outcomes as well as pneumonia. And again, the idea is not just to look at the epidemiology of saying whether there is actually an association, but seeing whether you can actually demonstrate reduced impacts when you actually have improved technologies being rolled out. So we're actually leveraging 2 NIH-funded studies in Nepal and in Ghana to ensure that we can actually have really clean interventions, including clean fuel intervention to look at. And there's also a study on adverse pregnancy outcomes in Nigeria, which includes both a firewood, a kerosene, as well as a clean fuel arm. And in this case, it's ethanol that they're focusing in on. And actually, I can see several kind of co-investigators and collaborators for these studies are actually in the room here today. So I don't know if those of you who are here want to just quickly raise your hands. I can see Amanda. I saw a few others in the back here as well. And so the idea here, I mentioned the exposure response curve earlier. We had been working during the process of developing the burden of disease estimations to really look and make sure that our risk factors and exposures were consistent across all of the combustion risk factors. So we worked with the ambient air pollution group, household air pollution group, as well as the smoking groups to see along the curve, if you look at, because they're all really combustion sources, if you look at the exposures, what are we really seeing in terms of the consistency here. And this is actually the curve for pneumonia, which of course doesn't include active smoking since young children don't tend to smoke. But I just wanted to emphasize that earlier here, we really had evidence from the one randomized control trial in Guatemala giving us this information at the higher level exposure. And then we had information at the lower levels for secondhand smoke around here, and then from ambient air pollution down here. What we're actually going to get for these 3 studies that are currently in progress are really information, for some of the kind of improved stoves that you see around here, the advanced biomass, and then the cleaner fuel arms. We kind of have a sense right now of what the range of exposures are going to be likely at these 3 different levels, but what we don't know is where the studies are going to kind of fall in terms of the increased risk. But this is something that'll be really interesting to kind of really get a better sense and kind of evidence from several places, different technologies that can actually inform how this curve really looks within this area here. And you can see that with the better technologies, we're actually getting into the range of the secondhand smoke and the ambient air pollution as well. Similarly, I think we have to think about how clean we have to be for adult health outcomes, and particularly for the ones where we'll be able to actually see a signal in the short term, really focusing in on some of the cardiovascular disease indicators. And here, also interesting to note that for where we think that the cleaner technology will fall in kind of the steeper range of the exposure response curve, so that we're likely, hopefully, to see even greater health benefits for adults than one might actually see for the pneumonia case as well. And then just quickly to emphasize beyond the air pollution, we're also very concerned about cooking-related burns and injuries. We know that there's around 300 deaths from fire-related burns each year on a global scale. 95% of these actually occur in developing countries. But until now, this has never been addressed in any kind of global risk assessment because we actually don't know what proportion of the deaths are cooking related. So we've actually been working with Centers for Disease Control as well as WHO to really establish burns registries at the clinical level so that people can actually get a better sense of what fraction of severe burns are cooking related, are related to electrocution, occupation, and things like that. And so this is really going to enable us to have more information going forward. The ISO standards process is also looking at kind of safety and injury as one of the metrics that they're actually focusing on in terms of development of standards there. And finally, we also would like to think about awareness-raising opportunities too, to kind of think about ways that we can make sure that cooking is kind of safer in terms of minimizing exposures to the flames there. And so just before I leave, I just wanted to give you a glimpse from the field. I mean, this is recently what I saw during a recent trip to Ghana. And I just wanted to mention it because it gives you a better idea of what things look like and also how you can think about how research and government commitments and other activities can actually converge. So Ghana is a place where you have around 3,000 deaths every year attributable to pneumonia that's household air pollution related. And the study that's actually being conducted right now in collaboration with by Contempo Health Research Center and Columbia University is a study that has 3 arms. You can see they're really looking at households that use a really traditional 3-stone fire and actually randomizing into 2 types. One is an advanced biomass stove that you can see here, or LPG in this case. And it's also a very interesting study because unlike some of the earlier studies, I think the new studies, because they're worried again about this issue of stove stacking where people keep using their old technologies, they're actually making sure that everybody kind of has 2 burner equivalents that they can rely on so that they have one stove to cook their carbohydrate on, another one to cook their stew or their gravy on, and so the cooking needs are met. And you can see here, for example, of interest here, the woman who's received these 2 advanced stoves, the original 3-stone fire is no longer being used. It's actually being used for storage now. So that was a very encouraging thing to see in the field. But it's also, I wanted to emphasize this because Ghana is one of the places where, because there's been so much active government engagement, we can actually see that the accessibility of these cleaner technologies is actually something which is really viable in the near future. They have a commitment to cleaner biomass stoves, but also a commitment to 50% of the population getting access to clean fuels by the year 2020. So it's just a very interesting kind of case study in terms of how things could progress. So with that, I'll end it.
Thank you very much, Sumi. And our next speaker is Chris Ebuy. Chris is a consulting professor at 3 or 4 universities and is beginning is joining the University of Washington this summer to start a new institute on global change in health, I understand, but she'll tell us more about that perhaps in the question session. She is a leading researcher on the impacts and adaptation of climate change, adaptation to climate change, including the effects on extreme events, thermal stress, foodborne safety, and security in vector-borne diseases. And her work really is focused a lot of our understanding around the vulnerabilities in designing adaptive policies and measures to reduce risks. She's worked very closely with WHO, UNDP, USAID, and others in this arena, and is now co-chairing with Tom Cram, International Committee on New Integrated Climate Change Assessment Scenarios. And she was coordinating lead author for the health assessment of 2 U.S. national assessments, the IPCC, the Millennium Ecosystem Assessment, and is very prolific. So thank you very much, Chris, for joining us.
Well, thank you very much for that introduction, and thanks to all of you for staying. I stand between you and lunch. The good news is I have 11 slides, that's one of them. The bad news is they're kind of complicated. It's my job to take all this wonderful research that we've just heard about and move it, as we would say in my community, to the top down. We've heard about the bottom up, doing work with communities, understanding on the ground, and then how do you synthesize that and come up with some suggestions for how to move forward. And I point this at something. That? Cool. I apologize. As you've noticed, all the slides are cut off at the top. Not a whole lot any of us can do about this. I want to start with just 2 slides to give you a sense of how much climate has changed. I want to talk about what we're seeing on the ground as a consequence of the change that's already occurred, and then about what the projections are for some issues that I hope are of concern to all of you, and then come back to what kinds of things does this mean for what we do about it. I'll start here at some wonderful work that Peter Stott has done in the UK. They took weather data from the late 1800s. When you look at climate change, all of our work starts in the late 1800s for a couple of reasons. One, that's when the Industrial Revolution started. That's when humans started seriously putting greenhouse gases into the atmosphere. And the other is that when it's the same time period, we started putting out thermometers and rain gauges. We actually have observations starting in about the mid to late 1800s. So Peter took data from the late 1800s and then used the climate model that they've got at the Hadley Center, ran some very large number of Monte Carlo simulations, saying we understand a lot at the global scale of how the climate system works. So we understand the kinds of drivers. Jonathan mentioned some. There's volcanoes, there's other drivers that affect our weather patterns. Let's run it through the model and see what would happen with temperature. And you see here the results of that simulation. I will mention that this is the baseline again here. How many of you did Z-scores when you were in your School of Public Health? How many of you liked Z-scores? I really didn't like Z-scores. These are Z-scores, essentially. It's what the climate community uses. And so this is your baseline, and that's what you would expect with weather patterns if humans hadn't been putting greenhouse gases into the atmosphere. And what Peter plotted on here is actual temperature change, to give you a sense of the magnitude of the change that we've already seen. Another simple example is this paper was just published, one of my graduate students in Sweden, Daniel Ostrom, and you can see part of the title, but it's winter months in Stockholm, and what Daniel did is he looked at two time periods. He looked early in the 1900s, and he looked essentially now, and plotted the kinds of temperatures at Stockholm, so the temperatures are kind of cool compared to other places. The white bars in the middle are the temperatures that occurred at the beginning of the century and at the end of the century. As you'd expect, there's an awful lot of overlap. These gray bars are temperatures that no longer occur. Those temperatures occurred 100 years ago. We're not seeing them anymore. For those of you who work on infectious diseases, think about vectors and what that means for vectors. Somebody asked me recently if the incredibly cold temperatures in the East and Midwest in the United States this year, if that means vectors like Aedes aegypti would be killed out. Well, the temperatures that Washington, D.C. saw were not that uncommon 30 years ago. That it's not going to affect really killing out of vectors the way it did at the beginning of the century. Over here are the temperatures that did not occur a century ago. And this is over a 30-year period that those temperatures are now occurring. And that shift is continuing to go. And you start thinking again about vectors and what that means for how they can change their ranges, what their season is, how fast they can reproduce, how many reproductive cycles that you have. This is complicated. It's not my slide. I will not apologize, but I wish they'd done a simpler one. This is from the just released Working Group 2 report of the IPCC. It's the report that looks at impacts, adaptation, and vulnerability. And what I want you to look at is, we'll just focus now on Africa. The little drop is water. The little tractor is farming. And the funny little thing that's supposed to be people is health. The bars next to it say how confident they are that impacts have already occurred. And what you can see as you look across the globe, you see lots of places where impacts are attributable to climate change. Attribution is a very formal process in my field. It follows strict rules, and it has achieved a very high standard of saying that there is a trend and you can attribute that trend to climate change. It's very difficult to do that in human health, mostly because our data sets are too short. And as been mentioned multiple times, there's lots of drivers of climate-sensitive health outcomes. We don't have sufficient data to tease it out. It doesn't mean climate change isn't changing anything, we just don't have enough data to figure it out. But you can see very clearly there's lots of places in the world that have already seen impacts, and will continue to see more impacts as the climate changes. I'll put both of these up at the same time. The framing that we use in climate change as we talk about the future, as we talk about risk. The extent to which we see impacts will depend on all the choices that we make individually and collectively. That when I talk about future risk, the extent to which those risks occur will depend on what we do in the short, medium, and long term. When you think about risk, risk is composed of 3 basic factors. One are the hazards. I just mentioned the hazards around climate variability and change. We can go into those after whoever would like to stay instead of going to lunch. This figure has been put together across multiple sectors, so the terminology is used a little different across sectors. What exposure means in other sectors is who and what's exposed. So you look at the geography, you look at vulnerable communities. It's a little different language than what we use, but it very clearly teases out you have to understand the places that you're talking about. And then finally, the underlying vulnerability. The same strength typhoon hitting the Philippines versus hitting Japan has very different consequences. Vulnerability matters. And you can't talk about future risk without talking about all 3 components. Whether or not impacts occur depend on a range of issues. When they do occur, they affect socioeconomic processes, they affect the climate. The emissions also affect both of those as well. So we're talking about a multidimensional system that we need to understand. There is a lot of understanding, and there's a lot that can be used. One of the key messages I would like you to take from this is there is a huge amount of information about climate and climate change. It's a risk for health. If this community, if the health community does not take that risk on board and does not take the actions that need to be taken, it's then our collective responsibility for future morbidity and mortality that could be prevented. In terms of looking to the future, I said these are all kind of complicated. These are the projections of temperature change. This is out to 2100. If you're real interested, I've got a slide at the end. It takes it out to 2300. This is a scenario with very low emissions. It actually has negative emissions by the end of the century, and this is more a kind of business as usual. Overall, we're actually above this trajectory right now. If we get up here, global mean surface temperature change at the end of the century would be about 5 to 6 degrees centigrade. It doesn't sound like a lot. It's the same difference in global mean temperature between now and the last ice age, to give you a sense of how large this change is. For those of you who work on things like infectious diseases, when you start thinking about ecosystems, our ecosystems developed in a time when the climate was stable. We're asking ecosystems to adapt in 100 years that in the past they took thousands of years to reach the same level of adaptation. That's why the work that Peter does is so important, because how do you facilitate adaptation at such an incredible speed? On the right-hand side is something that our community calls the burning embers for probably obvious reasons. Our community has looked at, when you think on the global scale of what the big risks are, I will try to read you these, looking way down here. So the first one is unique, I think it's threatened, yeah, unique and threatened systems. For those of you who live in the US, these are polar bears and those kinds of issues. The second is extreme weather events. The middle is the distribution of impacts. It says that there's highly unequal distribution around the world, and that will really matter. The fourth is aggregate of impacts. And the last is large-scale singular events. This is catastrophic melting of ice sheets. What you probably can't see is this little dot right here. This is where we are. I'm using this scale here because it's relative to the end of the 1800s. And this says moderate, is it high? It's high and very high risk. It basically tells you for all of these major global scale vulnerabilities, we're already entered into a period of high risk. We've lost the buffer. If you go back and look at what this slide looked like from the third assessment report that came out in 2001, we were still in the clear area of saying we haven't quite entered into that. We still have time. The message from this report is we're out of time. We have to start doing a lot to adapt. This is a 3-part slide. I'm just going to do this and then I'll click through it. This is a scale up here, and I really apologize because I can't see either one very well. The top is the present. The middle is the very near term. If you talk to a climatologist, they say 2040s today because we know what's built into the system. And then the bottom two are if there's 2 degrees C increase in global mean surface temperature or 4 degree. The blue part of the bar says how much risk would we have if we have very high levels of adaptation, if we implement everything that we know we can implement in terms of public health prevention. The gray part of the bar is what would happen if we kept our current level around all these climate-sensitive health outcomes. We'll go back here to Africa. Down here is water and vector-borne diseases. It says the risks are really high if we continue what we're doing. The risks will be high even if we do everything what we know how to do. It's one of the reasons why a number of us who work in this field keep coming back to this meeting, because you all work on these critically important issues. And taking on climate change is really vital. The programs that you work on, the studies that you do, we need to understand how to incorporate climate change to help prevent avoidable morbidity and mortality. And as I said, we've got the information that will help you to do that. And if I click through, here's other parts of the world, and there's all of them together. These graphics are downloadable if you'd like to see these in a lot more detail. It also includes on here water and food security, and both of those are, this century is going to be characterized by issues around water and food security. This is one of the summary slides that came out of the human health chapter for this report. They had a lot of fun making graphics, as you can tell. Present, this is the era of committed climate change. The greenhouse gases in the atmosphere have committed us to 30 years of climate change. And this is at the end of the century. As you go around, this is heat, vector-borne, occupational, mental health, extreme weather events, air quality, food and water-borne infections. The middle of the circle is about basically the baseline, and what this tells you is what the impacts would be. This one's the easiest to see here. What would the impacts be with high levels of adaptation, and what would the impacts be with no additional level of adaptation over what we're currently doing? Same information as a previous slide, but really focused specifically on health. And again, the same result, that if we don't do anything, the risk will be very high. Even with doing things, we will have additional risk over what we have today. I wanted to put this in as a counterbalance to what Jonathan put in earlier. This came from the World Economic Forum. When they met this year, they asked all the people who participated in the World Economic Forum to rate 31 different risks. And they asked them to rate on how severe the impact is likely to be and how likely the impact is likely to be. And climate change is here, and extreme weather events are there. The world business leaders think climate change is a problem. So to go back to the slide, and as I've tried to mention all along, if you think about all of what I've said of how to start incorporating this into what you do, into ensuring that your activities think about how climate change could affect their ability to achieve their goals. How can we think about longer-term resilience? A phrase that's used in the water sector that we need to use in health is stationarity is dead. I can guarantee that nearly every one of your programs were designed assuming temperature and precipitation will not change. They will. They already have, they'll continue to change. How will that make a difference in what you do? The answer in some cases may be quite large. So it's really important to think about this. There's a bunch of us who'd be happy to help you understand more. And then finally, I couldn't resist, it's a summary cartoon. For those of you who can't read it, it's the IPCC, and the conclusion is buy a snorkel.
don't have as much time for questions and discussions as I hope, but we have a few minutes.
Or they could
Yeah,
go to
hi.
lunch.
Pardon?
Or they could go to lunch.
Or they could go to lunch, but please stay there if you can. So start right ahead with, let's see, Michelle first, and then we'll go to the back.
So, Michelle Berry from Stanford. This is a question to Jonathan. So I buy in completely that deforestation is bad. But what I was thinking about is how do you really control for population in a pristine forest and in a deforested area? Because the demographics of you may be able to control for the number of people, but the folks that come in, and I've worked in Iquitos, that build the roads are more likely to have malaria than the people that are living there, and they're also possibly bringing in a different vector of Anopheles. So how can you possibly control? I do believe deforestation is bad, though.
Right.
But as a malariologist, I don't quite get it.
Right. It's certainly multifactorial, as all these things are, and bringing the parasite into a location is critical. So we're looking at migration rates over time. The field study with the entomology, we had many abandoned agricultural sites. So we could look at places where there was nobody nearby and it was deforested. So in those places where you'd say, well, if it's people, there ought to be this anthropophilic Anopheles darlingi species should be there because there are people there. But that mosquito was present in these abandoned sites. And so we think there's a link between the ecology rather than just a human driver. Now, the human driver is very strong, absolutely. But this is why we wanted to tease these out and specifically look at places that were deforested with no people nearby to help with that. We don't know the mechanism.
But those places were deforested by that particular group of demographic.
Right, but I don't remember the number of years as far as abandonment, but there were some that were, multiple years. Okay. Yeah.
In the back there.
Yeah, hi, Quentin Eichmann, Vanderbilt University. My first question was very similar to that, but maybe it has a different wrinkle, so I'll start with the second question. And that is, in terms of the debate this morning about supply and demand, I'm kind of curious where you would see the intervention in the sort of gas stove kind of happening, if it's supply demand, kind of where that can most effectively be made. And then, if you don't mind, I'm not sure I fully understood your answer, but in deforestation with the mosquitoes, what exactly, it's maybe a naive question, but gives the Anopheles mosquito a competitive advantage in those kind of settings? I didn't quite understand that.
In the interest of time, can I suggest we just stay with the first question about the supply-demand? Because we're unfortunately a little short.
Okay, so I'll try to answer briefly. I mean, I think this has been an area which has been a real issue, and why I think this the market-based approach that we've been trying to take to try to move things forward, what we've seen is there's two issues. I mean, one is this issue, particularly for cleaner fuels, of really looking at the supply chain and trying to see how you can increase distribution networks. I do want to add, though, that in some places now, for example, in India, we have, there are 3 states that are now almost fully electrified, and we've found that there may be some opportunities there for this induction stove technology seems to be also taking off. But also, I think it's in terms of increasing demand, we've actually focused for the first couple of years on really trying to strengthen the supply chains first to make sure that there would be something available in order that you don't increase demand without having something accessible. But there's been related to that, we've been really thinking about how you can think about innovative financing mechanisms to make sure that people can actually access, because a lot of times there may be some difficult upfront costs that people cannot really get over. But if you're able to address those barriers, then actually the cost of the cleaner fuels may actually be cheaper than charcoal or even purchasing a biofuel in many places. So,
Of course, I might add that the trick is making sure that the stoves and the fuels are clean enough to produce a health benefit, and we're still working at getting the evidence to support that.
Yeah, and I think that's why my answer for the health side of things, I think it's really only the cleaner fuels that we are really much more confident about at the
You
moment.
don't want to supply stoves that are not actually producing a health benefit.
And
In the middle
very,
there?
very quickly, we don't know the mechanism of how deforestation leads to the increase of that mosquito. We did see, of course, you've got more open sunlit pools of water. We have different algae growing in the water, different plants along the edge of the water. We don't know what the effect is, but we observe that difference. And one of my colleagues, who's an ecologist, thinks that it may be the temporary nature of those disturbed pools, and there's no biodiversity. And he said, well, the dragonfly larvae eats tons of mosquito larvae. So we don't know the mechanism. We need the aquatic ecologists in there to help out.
Hi, I'm Jenny Binstock. I work at UCLA. I was wondering if you could comment on the state of how global health programs at universities are incorporating land use, climate change, these big environmental questions with big consequences. I mean, I know that's probably a bigger conversation for our limited time, but what is being done? Is it being done effectively? What would require that to be done sufficiently?
Well, I'll only speak from the point of view of University of Wisconsin in Madison. I can tell you that we are extremely proactive in trying to bring all the colleges on campus into this, so that we don't want to have a new project that doesn't have an engineer, economist, environmental scientist, sociologist, anthropologist. We don't want to do the stuff, we want to bring in, and so it's happening. And at least our institute, we are not in a school. I report directly to the provost, so we are, by definition, able to cross sectors, cross disciplines, and have a very integrated approach. So I think others all over the place are doing that as well, but not as well as us.
Okay.
Internationally, there's a lot of programs that are doing this. The U.S. has been the slowest to take this up as an issue, but I think most universities are working quite hard to make sure that they add it to their curriculum. A challenge has been that there has been such little funding, there's so few people trained, that there are lots of places that would like to add this expertise and they don't know how to get it.
Yeah. Phil.
Hi, Phil Landrigan from Icahn School of Medicine at Mount Sinai in New York. So this is more of a comment than a question, but somebody will respond. I wanted to touch upon another aspect of the changing global environment that's been hinted at today, but not really focused upon, which is the global diffusion of toxic chemicals. Peter Piot this morning mentioned the occasional disasters like Bhopal, and those are certainly important. Those are punctuation points. But underlying that and continuing on a steady basis day in and day out is the global spread of toxins. And very briefly, since it's just before lunch, to tick off three. Number one, asbestos. The global production of asbestos continues at 2 million tons per year, and virtually all sales are to low and middle income countries. In India, for example, consumption is increasing at 10% per year. This is a public health disaster in the making, but on a slow time course. Number two is toxic pesticides. About 20% of the pesticides that are produced in the US and in Western Europe are pesticides that we don't allow to be used here, and which we therefore generously send to countries that don't have enough toxins and that are producing heavy exposure. And a third is e-waste. The amount of e-waste that is being produced around the world as we discard our computers and our cell phones is just in the trillions of tons. And most of it is ending up in a small number of places, Ghana, some places in South China, some places in India, probably a few more. And in those localities, it's an environmental disaster.
Yeah. Thank you. Thank you for that.
Let me comment briefly on that. I think it's a really good point, but to make it a positive point, because it's kind of depressing when you start to think about all the other things that are going on in the environment, I think there's a real opportunity here that we need to grasp as a community, which is the complexity of these issues and doing the right research that brings public health together with ecologists, together with people who actually go out on the ground and make change and do interventions to really make a difference. And I think you touch on big issues there. Pesticides and the way they simplify ecosystems and lead to further erosion of ecosystem services has a huge impact on health. but people just aren't measuring that yet. The public health community is just beginning to grasp climate change, but what about biodiversity loss? What about, the loss of forests? These are big issues that ecologists have been working on for many, many years and have done really complex, really good, rigorous, hard science on. I think there's not only an opportunity for great programs in schools of public health, but there's some great research. There are going to be great papers in Nature and Science and Lancet and New England Journal on these things, and it's going to grow. This is a growth area that you guys should get involved in. It's a great area to work for a PhD and develop the research and make a big change in the future. So thanks for bringing that up.
Yeah, thanks. I think actually Phil's final point about is quite important about and Peter's follow-up note about the way that we can approach these things with research and understanding increased surveillance, that it will take teams of toxicologists and classical public health people, but as well as ecologists and physicians and health service workers, and increasing complexity of analytical tools to be able to take downstream problems and come up with solutions that are manageable. We have to be well informed about the causes and the distribution of these at a local level, and then how you generate solutions is I think the challenge of the future.
Part of that challenge is to encourage people here who fund research and people here who are responsibles for university programs to think about how those need to be restructured. The incentive right now for scientists is individual publications. A real message for the IPCC winning the Nobel Peace Prize is it's no one person anymore that can solve these problems. That we have to change our incentive structures so that those of you who are starting out in programs have incentive to go and talk with the ecologists, and you will get more bonus points, however you're awarded bonus points, for working across departments. And that is a structural problem within universities. Josh has got power to help make that change. Other people at NIH have power to make that change. NSF is already starting that change. They're putting out all kinds of calls for proposals that say they have to be multidisciplinary. If they're not, you need not apply. And there has to be a lot more of that. And so we need to do both, excuse me, from the university and from the funder to make sure that we have the incentives, because everyone wants to get to that place.
Super. Any final questions or comments? Well, with that, I think, I have one very important final note, and that is, because it's Mother's Day, and I asked several of these panelists to leave their families at home.
That's brownie points.
Something either for you as a mother,
Supporter of
or
a
to
mother.
take home to your family.
Thank you so much. That was really nice.
That's great. Yes, thank you all very much. That's,
Fantastic.
Wow, thank you.
Nicely done, Josh.